All right. Our next speaker is Paul Mason, another sports medicine and exercise physician, who's going to be talking to us about lower back problems.
So, good morning. My name's Dr. Paul Mason, and I'm a sports and exercise medicine physician here in Sydney. And today I'd like to talk to you about some surprising research regarding nociceptive generation in uncomplicated low back pain. And by uncomplicated low back pain, I mean that which has no complicating features of yellow flags, psychosocial stresses, or evidence of neural sensitization. But importantly, the lessons we can learn from some of this older research can be effectively integrated with a contemporary model of pain science. And this integrated approach can help both reassure the patient and lead to enhanced patient engagement. And this can lead to better patient outcomes. So it's currently accepted in the medical literature that nociception should not be an important focus in the management of non-specific low back pain. In fact, it's widely considered that we don't even know the precise pathoanatomical causes of low back pain, which structures contribute to low back pain. And this comment here was from a recent article published last year in The Lancet. But I think this perspective is wrong. We know that pain is a multifactorial experience, and in some cases, nociception may even be absent in a pain state, but there is strong evidence for the role of nociception in at least some low back pain cases. My view is informed by some quite old research. A lot of research that was done in the pre-internet era was not effectively disseminated, and it seems to be that we've got a healthy disrespect for any research older than about 20 years. And the result of this is that a lot of the research that was done in the past has effectively been lost. But some of this research is incredibly unique in that it will never be reproduced. And the simple reason for this is that it would never pass muster with a modern-day ethics committee. So while this research may not be ideal, we should glean from it what we can. So I'd like to start by looking at the pain chart of one of my patients. This is a 34-year-old mother of two, and she had an increasing ache over her low back, and she presented to me with an MRI from her GP. Now, normally, I wouldn't image the sacroiliac joints in this type of presentation, but let's see what they showed. You can see here the sacroiliac joints looked quite pristine on this coronal slice. But when we look at the sagittal slice, we can see something funny going on with one of the discs. So the L5 S1 disc was captured in this slice, and we can see a posterior protrusion. Now, this posed a bit of a question. Lots of people have disc pathology, and many of them have no pain at all. So the question was, could this disc protrusion explain her low back pain? Now, we have to be careful because over-attribution of imaging findings has contributed to many a pain state in our patients. Careless use of language regarding what are essentially incidental findings can really increase the risk of chronic pain. That leads to unhelpful beliefs, fear avoidance behaviour, and so on. But likewise, it's well known that the outer 1 to 2 millimetres of the annulus fibrosus is richly innervated with nociceptors. And there are some historical papers which demonstrate the ability of this annulus fibrosis to contribute to low back pain. So let's have a look at some of this research. In 1949, Wiberg, a Swedish surgeon, published a case series on 200 patients he operated on while awake. Probably a study that would struggle to get ethics approval today. So he used local anaesthetic to provide pain cover right down to the ligamentum flavum, and then he exposed the intervertebral discs. He then probed the back of the discs to assess the pain response. So picture this, the patient's awake, they're lying prone on the table, they've exposed the disc, there's no local anaesthetic over the disc, and he's now probing it. And what he found was that in almost all of the 200 cases, he was able to reproduce their pre-operative back pain. And the pain they experienced was qualitatively similar to their previous experience of low back pain. And this certainly suggests that garden variety low back pain may indeed be contributed to by annular irritation. In the same year, Carl Hirsch published this paper, and he injected discs with up to 2 mils of normal saline, and he found that he could generate what he termed lumbago by simply increasing the pressure within the disc. And then when he instilled local anaesthetic, this effect was reversed, again supporting the pain-generating features or properties of the annulus fibrosus. We then go 9 years later, 1958, and this paper was published by an orthopaedic surgeon from England. And at open surgery, he passed loops of nylon thread through and around various anatomical structures, and he left the free ends of these threads coming out through the wound, which was then closed. In one of these patients, they passed a thread through the outer aspect of the annulus fibrosus. And the day after the operation, they pulled on these threads to see what would happen. Again, would struggle to pass muster with an ethics committee today. Initially, he felt nothing, but after about 30 seconds, he started to report the onset of a gradual, intense ache, described by the patient as ordinary low back pain. Then in 1991, there was another series on 193 patients who were again operated on while awake. And this was much more comprehensive than the previous study, which we've already seen by Wiberg. So basically, they used blunt compression and electrical stimulation to test every anatomical structure which they could reasonably identify. And interestingly, many of the anatomical structures which as therapists we attribute to causing pain were found to be relatively insensitive. In actual fact, you could cut the fascia without any anaesthesia at all. The major finding of this study, again though, implicated the role of the annulus fibrosus in low back pain. In 2/3 of patients, stimulation of the annulus fibrosus always reproduced pain similar to their preoperative pain. So coming back to the young mother with low backache, it is plausible that some of her low backache could be contributed to by stress within the annulus, given that we saw evidence of the posterior disc bulge at L5S1. But we have to be careful. Given that these lesions frequently spontaneously improve, more than 2/3 of them will improve even without treatment, and we know that a lot of disc pathology is actually pain-free, we have to be very measured and balanced in how we communicate with the patient. We have to make sure that we don't create any unhealthy beliefs or fears. But I want to now explore different patterns of pain that can arise from nerve root compression. So we tend to think of pain arising from nerve root compression as being sharp or shooting. Nerve compression can also lead to a muscular type pain though, pain that patients describe as a muscular ache. So this is a pain chart from a 44-year-old barista who first came to see me in January, and he had an intense ache over his right glute. And it was likely coming from S1 nerve root irritation. Now, over time, he was actually going really well. And then he took a long-haul flight to the UK in April. And then this happened. The ache in his right buttock got a lot worse, and he also developed a sharp pain down the back of his leg. And both of these pains were caused by irritation of the S1 nerve root. Now, our traditional understanding of nerve compression pain explains the sharp pain down the thigh, but not the ache in the buttock. So to understand the ache in the buttock, we need to take a closer look at nerve anatomy. This is the posterior interosseous nerve. It's a motor nerve, and it doesn't have any sensory supply to the skin. But when it gets compressed, it presents with pain. Now think about this for a second. How does that make sense? A motor nerve presents with pain when we squash it, and a lot of us have probably seen this in our clinic. And this only makes sense if we understand that all nerves, even motor nerves, have their own sensory nerve supply. So here's a close-up of a nerve, and you can see the small nerves and vessels, which are in colour, supplying the nerve sheath. And these small nerves are called the nervi nervorum. And the dural sheath around the spinal nerves in the region that can be compressed by discs also have similar sensory nerves. So let's consider what that means for a moment. Irritation of the periphery of a nerve and the associated small sensory fibres can often cause pain which is felt as a deep muscular ache. And when we compress a nerve more significantly, that can then lead to disturbance of the transmitting signals, then leading to motor and sensory symptoms. So in the barista, it's likely his initial pain was due to irritation of the periphery of the S1 nerve, and after his long-haul flight, when the compression likely worsened, that then subsequently led to the development of that more significant pain down the back of his thigh, which was described as radicular, that sharp electric shooting type pain. So let's go back to this paper where they looped threads around different structures. And this demonstrates rather elegantly these two different patterns of pain. In 26 patients, nylon thread was looped around one or more previously compressed nerve roots. And after they pulled on the strings, a few weeks after surgery, this is what they found. This is the first pattern of pain with gentle traction around the S1 nerve root in two different patients. And both of them described the pain as a deep and muscular type of quality. But what happened when they pulled a little bit harder? Well, this happened with more forceful irritation, again of the S1 nerve roots, pain that's typical of the radicular pain which most of us are familiar with. So to recap, irritating the outside sheath of a nerve with those small sensory nerve fibres can cause local pain response that's typically felt more proximally and as a muscular aching type quality. But if we more forcefully compress a nerve, we can interrupt the conducting signals, and that's when we experience the classical shooting pain that we associate with a radiculopathy. So, with this understanding that low back pain may arise in part, possibly from annulus stress, from nerve root pressure, it makes sense that anything that increases the intradiscal pressure within a disc might actually contribute to symptoms. And the corollary of this is that anything leading to reduced intradiscal pressures is likely to be beneficial. So let's have a look at two things that can modulate the pressure within a disc. The first is time of day. Basically, when we lie down at night, our discs imbibe fluid. And when we get out of bed in the morning, that extra fluid combined with axial loading leads to higher intradiscal pressures. This is a T2 weighted MRI with colour mapping showing hydration of the intervertebral discs. The fluid in the disc spaces is indicated by darker shading, and this was taken in the morning. Later in the day, we can see the fluid content within the disc is significantly reduced. In fact, 25% of the fluid content within a disc can be gained and lost over the course of a day, and this is actually reflected in changes of disc height. And this is why we're taller in the morning. This here is a graph from a study showing that on average, our height varies by almost 2 centimetres over the course of a day. We're tallest immediately on getting out of bed, after which we rapidly lose height. In fact, over 50% of the height loss occurs within the first hour, and therefore the disc pressures, the at-risk period is that first hour after rising. This belt here was worn by a subject in a study investigating changes in disc pressure and posture and movement. At the end of this probe is a pressure manometer, and that was inserted inside the disc space. This is an X-ray of the probe sitting between the two vertebrae, and this study again falls into the category of those unlikely to ever be repeated. But we still get some really good information from it. Here's the study volunteer wearing the belt. He's performing a manual handling task as a part of the study. And these are the results. First of all, note that the lowest intradiscal pressures occurred lying down and sitting back reclined, leaning back. Both of these indicate the contribution of axial loading from gravity on intradiscal pressures. But next we can also see that postures with a flexed spine, such as sitting and leaning forward, also appeared to have higher intradiscal pressures. And this is really significant because it gives us something that we can work with, something that we can use to control pressure in discs. So we've established that disc pressures are higher in the morning and also higher with flexion. So what happens when we flex the spine early in the morning? Well, the disc stresses for the same degree of lumbar flexion are actually 3 times higher. That's 3 times higher when performed in the morning compared to being performed in the evening. And this perhaps explains the high rate of low back pain that I see in a lot of my athletes, the kind of athletes that do their training in a flexed spinal position early in the morning. Rowers trying to get some clean water and cyclists trying to beat the traffic. And interestingly, there is some research that indicates that stretching activities are actually associated with an increased risk of developing low back pain. Now, this type of research doesn't prove causation, but it does suggest that we should exercise a degree in caution in prescribing spinal flexibility exercises in patients with low back pain. So then, what are the effects of avoiding flexion in the morning on low back pain? This paper here is one of my favourite studies ever. It ought to have been a seminal paper in the management of low back pain. As of this week, though, it's only been cited 3 times in the medical literature. It's almost been lost. The intervention within this study was based on the premise of avoiding spinal flexion for the first 2 hours of the day, that early period when intradiscal pressures are higher. Subjects were taught how to log roll to get out of bed. They were instructed to avoid all bending, all squatting and all sitting for at least the first 2 hours after rising, and they were given education and advice on how to perform the ADLs, like brushing their teeth, without any spinal flexion. After the first 2 hours, they were then permitted to sit and squat, etc., only so long as they maintained a neutral spinal position. So what kind of results did they get? Well, the results were nothing short of impressive. At 6 months, the average pain reduction in the intervention group was 5 times that of the control group. And this was a significant advantage that was still present to a degree after 12 months. And these results were highly statistically significant. And at 3 years follow-up, those patients who had continued to avoid flexion in the morning had a 51% reduction in their overall pain days. So what happened to my 2 patients, the young mother and the barista? Well, we educated both patients about their diagnosis, and this is incredibly important because patients need to be reassured that in most cases their prognosis is actually very good. We know that about 2/3 of disc prolapses will spontaneously resolve when we image them serially with MRI. And with appropriate education about how they can take control, they get a sense of agency over their symptoms, and it tends to reduce their stress levels and the amount of distress they feel relative to the amount of pain. Fortunately, neither of these 2 patients had any complicating psychosocial factors of significant note, and neither of them had any evidence of central sensitisation. So we proceeded with a postural management program with the help of the patient's own physios. And both patients went very, very well. At the last review, the mother was completely pain-free, and the barista was reporting pain at 1 to 2 out of 10 on long drives, but he was very happy to put up with that, and because he knew what it was, he wasn't bothered by it at all. So I'm just going to briefly outline the postural management protocol which we used, and this is actually going to be uploaded to the Orthosports website in the near future. First of all, we apply a proprioceptive tape over the lumbosacral spine, and this is key, and this can be left on for several days. And this assists the patient in identifying whenever their spine is going into flexion because the tape will pull, and this is a key facet of the program. We teach patients how to get up out of bed with a neutral spine. We teach them strategies to avoid spinal flexion with ADLs, And here you can see elasticated laces in the middle, which combines very effectively with a long handle shoehorn to reduce the flexion. It's often these tasks of putting on our socks and shoes in the morning where we take our spines into extreme flexion. So a couple of these little assistive devices, and the OTs and the audience will know exactly what I'm talking about, can make a huge difference. We provide a lot of education on sitting, and if sitting's unavoidable, for instance, you have to drive to work and you don't want to get up at 4 o'clock in the morning, then a reclined posture with an appropriate use of a lumbar support is very effective. And remember that with the tape applied, the patients will be able to tell when their spine is being maintained in that healthy neutral position. And teaching manual handling is also key, because this then allows the patient to maintain their function and their occupation. And it can be very powerful for patients when they realise that they can do things such as picking up their child from the floor without hurting their back. And this kind of empowerment is incredibly useful. For higher level patients, we usually will progress to more advanced functional training. And as a final point, you must always be on the lookout for yellow flags and central sensitisation. And while the research I've presented here today provides an excellent model on which the treatment for uncomplicated low back pain can be based, if you fail to identify confounding factors like unhealthy beliefs or secondary gain, then it's really going to stymie any progress that you can hope to make. And there's also a number of other treatment modalities which we also utilise, which I don't have time to cover today. But some of these are also described in the handout, which is going to be uploaded to the Orthosports website. And another great resource for chronic pain is what we call the NOI Group website. So that's NOI. If you just Google NOI Group, they have some absolutely fantastic resources focusing on some of the neurocognitive contributors to pain. So the take-home message today is to be aware of the different types of pain that disc pathology can include, and that's a hierarchy. Annulus sprain might cause that midline low back ache, and then if you start getting nerve root irritation, gentle nerve root irritation will lead to pain that's usually described as muscular. This is the kind of pain we've all heard, hamstring-related back pain. That's probably what's going on, and different nerve levels actually will refer pain to characteristically different areas. And then with more significant nerve root compression, we're going to see the more classical radicular symptoms. But if you can identify that, then this postural style management program is a really effective adjunct as a part of your package for other treatments that leads to effective management of low back pain. Thank you.